Mr. Chairman. My name, Mr. Chairman, members of the committee, thank you for allowing me to speak today before you in favor of AB 104. And I'm Dr. Paul Young. I'm a board-certified general pediatrician with over 36 years' experience, most of it in Wisconsin, practicing here now, and I hold a master's degree in bioethics. Imagine with me a world where every child or teen is happy with their natural body, but sadly, we're in the midst of a gender dysphoria epidemic. Over the last 15 years, the rate of children being unhappy with the biological reality of their bodies has skyrocketed up to 5,000% all over the Western world. And these children have come to believe or been told by someone they're in the wrong body. Upwards of 80% also struggle with preceding mental and emotional challenges like depression, anxiety, autism, and ADHD. Many are suffering from past abuse, and some are so unhappy they do want to harm themselves. Now, some in the medical profession feel the best way to handle this is to agree with them, to say, you're right, you are in the wrong body and you need to be fixed. You'll need to learn to walk, talk, dress, and act like someone else, and then we'll give you puberty blockers, cross-sex hormones, and ultimately surgery to make you look like someone else. And parents are told if they don't consent to this, there's a high chance of suicide, so they must go along or risk losing their child. But all this comes at a terrible price. These approaches have side effects. Social transition reinforces the idea that they need to be someone else and virtually guarantees it. Puberty blockade can damage the developing brain, weaken bones, cause infertility. Hormones increase the risk for heart attacks, strokes, liver damage, and blood clots. They can worsen depression, anxiety, cause aggression, and mood swings. And by the way, there are controlled substances. These blockers and hormones can leave a child with physical changes that don't fully withdraw if they're stopped, including sterility. Surgery is very permanent, like the 12-year-old in California who is suing Kaiser over having breasts removed. There's no going back for her. But does it all work? Does it stop the pain, the suicide? Does the dysphoria and mental turmoil calm down? No. Recent studies are showing after 15 years and thousands of children, they aren't getting better. The Tavistock and Cass reports in the United Kingdom resulted in a halt to gender transition treatments for minors in favor of psychotherapy, and similar actions have occurred in Sweden, Norway, Finland, and Denmark. U.S. studies have also shown that medical transition can make kids worse, with more psychotropic medication use, persistent poor mental health, and ongoing suicide risk. Now, in the past, we worked with these children to accept themselves just as they were. It worked too. About 80% got better. They were usually happier and got the help they needed for their preceding mental health troubles. You know, it's hard to imagine how helping someone learn to be okay with their natural body would be called conversion therapy. How can we expect a child of 8 or 9 or their parents to consent to a medical transition when they don't know that that child won't change their mind? Just like the 13% by research that I've quoted in your stuff that are now detransitioning. How tragic to go through this just to discover your body was good as it was. Now, I'm in favor of doing what helps, to help a child learn to love themselves for who they are. It's safer, kinder, and it works, and that's why I'm for AB 104. Thanks. I appreciate it. 259. We tried.
So I think in this case, we'll take questions for Paul, because I see that Steve is registered against.
Yeah, and again, if you'd like me to switch, if it's totally up to you. I apologize.
Okay. If we've got questions, I know we've all been asking for doctors, hopefully we've got a doctor ready.
Yeah, and I practice in this state.
Is actually really for the chair, and I know that the next gentleman who's going to speak is speaking against, but I've noticed that he wasn't the person you called. We've had a consistent number of speakers for, and I know we have lots of people against in the room. Traditionally, there's been at least some effort by chairs to alternate, and I'm hopeful maybe we can start alternating.
We are getting to that, and that is at the discretion of the chair, and you'll notice that I let your Senate colleagues speak towards the beginning too, which I believe is the right thing to do.
Sure, which is traditional as well. It's a request. I understand it's at the discretion of chair.
So do you have a question for Dr. Paul?
My request for the chair is that we begin alternating to ensure that
And
folks
we
have
actually
time
will
to
next.
stay
I honored your request, so. All right, Representative Brooks.
Yes, sir.
So you are a doctor of medicine?
Yes, I'm a board-certified pediatrician, and I'm licensed in the state of Wisconsin. I recently retired from full-time practice, but I still do fill in for my employer. So yes, I am a practicing physician.
Can you speak to the question I had earlier regarding puberty blockers and sexual hormone treatments? Are they a form of sterilization in most cases?
Yes, if you do as they say, TAN or 2 refers to a youngster that's just at the very brink of going into puberty. If you apply those drugs, a puberty blockade, the way it's designed to by the original protocols that were developed in 2010 in Holland, and then you follow them with cross-sex hormones, it's a virtual guarantee you're going to sterilize that person. That's why they have developed fertility preservation protocols for those patients, because they realize this does occur. So yes, that is correct.
And if I came in as a parent and said, I want my child sterilized through that method, would that violate your Hippocratic Oath?
I say that again, sir.
If I brought my child in and said, I want them sterilized via that method, would that violate your Hippocratic Oath or do no harm?
That's not, no, yes, sir, it would violate the Hippocratic Oath, and we would not do that. It would be a form of abuse.
All right, thank you.
Do we have questions from the committee for Dr. Paul?
Yes.
All right, yep, Representative Schneider.
Thank you for testifying. This would be your opinion, maybe not medical, but your opinion. Why do you think the Children's Hospital of Wisconsin and the Wisconsin Medical Society would be against this bill?
Would be against it?
Yeah, they registered against this bill.
Okay. Far be it from me to speculate on all of the motives and
the AMA, yeah.
issues of other people. I can't, I'm not clairvoyant, but I would say that there are a variety of reasons. I think good people of goodwill do disagree on approaches. Obviously, it's been mentioned that major organizations do disagree, but there is such a thing as activism and advocacy, and that does influence people's decision-making. Also, these programs do generate income, and so there is a multi-billion-dollar industry in this country related to this, and that's, I think, truthful. While I would not ever seek to impugn the conduct of my colleagues or state categorically they are one thing or another, because I can't say that as an ethicist as well as a doctor.
Right.
I would also have to say that the possibility of a conflict of interest is always there. I think we just really want to be sure we're putting the patient first based on excellent evidence of which that does not exist. And it's been shown progressively more as we go on that it doesn't. And as a result, I think it would be most unwise to continue.
Do you think that you're in the minority, or do you think there's a lot of silent doctors that just aren't speaking out, similar to conservative teachers at a school?
Again, I can't speak for everybody, but I'm a member of the American College of Pediatrics. And I'm also have gone to conferences with the American Academy of Pro-Life Obstetricians and Gynecologists. They have over 8,000 members. I don't know what the current membership of ACP is, but I'm sure it's a couple of thousand. I don't know if we're in the minority or not, but we're certainly interested in the well-being of children, and we're deeply concerned that this ain't it.
Thank you, Doctor.
Representative Wickers.
Sir.
Thank you for being here, Doctor. I can tell by the color of your hair that you're a mature practitioner.
You're so kind.
You've been around long enough to see, are there parallel type of therapies that children has taken on that they've then 10, 20, 30 years later have said, we're changing our protocols and our recommendations on certain types of invasive or systemic therapies for certain types of things? And is it possible that children's in short time could see what the world medical community is saying, psychological community, pediatric community is starting to say, because of the full circle studies in this experiment, that children's may in very short time say, we no longer support the level of therapies that we've now been practicing, whether we admit it or not?
Yeah, the answer to your question is absolutely. There's no stare decisis in medicine. There was a saying when I was in medical school, 50% of the stuff we tell you is wrong, we just don't know which of the 50% it is yet. And that, after 36 years, if you count the residency, 40 years, at the UW, by the way, it's changed. Virtually everything in medicine changes. There's not a surgical approach, not a medical approach. How I treated ear infections has changed dramatically. Everything has changed. So yes, everything is subject to change in medicine. There's no sin in that. That's because you learn as you go. Hopefully, you study something before you act rather than after, which is one of the big problems that we've had with this. This was a takeoff of a very small, badly done protocol that was exploded all over the world, and later, after the fact, when no corroborating other research could be found, it's like a freight train that got moving, and then, now we're looking at the wreckage and going, oh, maybe this really wasn't such a good idea. And I know this is hard. These people here are very invested in this topic, and I feel for them. I have patients myself who have gone through these issues, but I also know them to know that that wasn't their issue to begin with, and I think they were kind of moved into this through social contagion and things. Back in the 90s, these children were treated very differently, and they were very successfully, particularly young children who exhibited that proto-gay behavior, were treated to help accept their bodies for who they were, and they were quite successful. And it was good therapy, and it avoided a great deal of intervention, which was painful and hard on them. And I referenced in my talk, on the documents that you have, Zucker's research, and Zucker and Bradley did beautiful work on biopsychosocial models of this. So did Paul McHugh at Johns Hopkins.
And then the quick follow-up. We see that other countries are moving way before us.
Absolutely.
Are we 10, 20 years behind them? And with the 2020 vision, is it possible? Do you think it's possible that the scientific community, the medical community, might say, let's just catch up?
Well, that's what the author of the Cass report, Dr. Cass, which was petitioned by Her Majesty's government, His Majesty's government now in Great Britain, to review this, called out the American Academy of Pediatrics findings and said they need to update their outmoded policy. And that's the same thing with the European Psychiatric Association has started to call this out as well. We need to catch up. This isn't good medicine, and we need to accept that and try to adjust to do better for these children than what we're doing.
Do we have any other questions from the committee for Dr. Young? All right, Representative Johnson.
Yes, ma'am.
Thank you, Mr. Chairman. Thank you very much for being here. You gave the example of ear infections.
Sure.
And that you learned throughout the course of your practice to change how you treat ear infections. What caused that change?
Well, over time, we have progressive access to research and better findings, and also the patient changed. In other words, the way you're using a specific example, but
You gave the example.
yeah, well, I gave you that example, but you're calling it out. And the methodology that we would use 20, 30 years ago, the drugs don't work, the organisms have changed, and the way the patient responds changes. Likewise here. The original research that founded the DSM-5 was before the epidemic of rapid onset gender dysphoria, which makes this entire enterprise unstable to begin with, because as the woman testified previously, the research scientists pointed out, the categories don't even apply to these patients anymore. They're not even valid for the protocol that was used in 2010. The De Vries and Coten-Kahanis protocol out of Holland was done on people who deliberately did not have any evidence of any other psychopathology, any other emotional, mental difficulties. Also, it was done mostly on people who were quite a bit younger. So the current people that are presenting are an entirely different patient population.